Thanks so much, Axel and Dr. Elson, for the invite. So these are my disclosures. Main learning objective I wanted to focus on from a management standpoint, as well as supportive care updates as well, which would be relevant to the novel agents, including IO, as Axel pointed out, but also I'll briefly touch upon some of the approaches relevant to prescribing and management of TKIs, and also other supportive care measures that are also important in patients with cancer. So starting with TKIs, two studies to really highlight and point out is the REDOSE study. This was done in patients with colorectal cancer, where two things were done. Essentially, there was preemptive rather than reactive prescription of clobetasol. Hand-foot syndrome is an important side effect, and sometimes it can be debilitating. So the use of preemptive steroid prescription to rather than waiting for the hand-foot syndrome to happen, and alongside the recurrent theme in TKIs seems to be less is more. So the 80 milligrams starting dose as opposed to the 160 milligram starting dose, and escalation by one pill at a time, which is 40 milligrams if well tolerated. Not only, not surprisingly, had better quality of life, but in fact the overall survival historically was better than some of the initial studies that came out with regorafenib that led to the approval. Similar lessons from not a trial, but sorafenib real-world data, where more than 3,000 patients who got standard setting dose versus patients who started off on half the dose of sorafenib. Again, non-inferior survival, better quality of life, lower risk of discontinuation, and staying on therapy. We talked about TKIs, the last two talks and debates. The durability of these new agents would be better if the patients could tolerate it better. So the dosing here for both the TKIs is applicable to many disease types within GI where this is being used right now. Moving on to immunotherapy, I think the most important document to be aware of is now published in JCO in June of 2018. I think it's a very well-described, descriptive, and practical document pertaining to IO side effects. And I'll walk you through some of the things that they have done. So immune-related adverse events, or IRAEs, not only have they included the grading, but they've included exact practical steps of what to do with the side effects if you were to have them. This not only talks about general approaches, but also specific dosing recommendations, the consults that you need to place, the tests you may need to order, the differential diagnoses you may need to consider. So for example, let's say take about grade 2 rash or dermatitis. It talks about consider holding it. It talks about monitoring. Does it have to be weekly? Does it have to be bi-weekly? It talks about what to do if it's not interrupted, and if it goes down to grade 1, what to do. It talks about dosing of prednisone or equivalent, so it tells you 1 mg per kg, or talks about topical imponents, talks about consulting the appropriate teams. Moving on to colitis, for example, it talks about holding it temporarily. It talks about what supportive care prescriptions to consider, making sure we rule out infectious causes, example C. diff, where to get gastroenterology involved, what steroids to give. And then it also talks about tapering of steroids too, because you'll hear different prescription patterns, how to go down, what's the optimal dosing, how long do I take steroids, when can I resume my IO, especially patients who are having a robust response, they would want to resume the treatment back. So this, again, can't emphasize and reiterate more that this is an important document. For example, pneumonitis, these side effects are rare, but when they do happen, they can be life-threatening as well. In terms of, when do you consider a bronchoscopy for a pneumonitis? When do you do empirical antibiotics? For example, here, you need to monitor them every 3 days as opposed to weekly for some of the other side effects. Pneumonitis, in our own experience too, when it does happen, when it's severe, it can deteriorate pretty quickly to becoming life-threatening. So again, talks about inpatient admission and IV steroids, and also other drugs that we may or may not be familiar with. For example, the use of infliximab or mycophenolate, or when to give IVIG. So it is increasingly seen that multidisciplinary involvement at your institution, depending on if somebody from, let's say, rheumatology has an interest in managing some of the side effects, is increasingly being employed, or somebody from dermatology when it comes to anti-GFR rash or IO toxicity. If they could, hand in hand, if you could identify the champions who are at your institution, I think that sometimes can be of value. So for them to help you manage some of the side effects, or consider biopsies where appropriate, as opposed to you managing them completely on their own and alongside, obviously, rheumatology, there is also the role of endocrinology, hypothyroidism, which can again happen at any point in time during the course of an IO treatment. Again, this document is very relevant and practical. It even talks to you about what dosing to give of Synthroid, which, I know all of us train in internal medicine, but in terms of after having trained in oncology, if you see a patient with hypothyroidism, when do I worry about the TSH? What dose should I use? What do I do about the dosing in elderly, which again, geriatric oncology is becoming a separate field altogether. So again, a very practical, very helpful document, because if you look at management of IOs, a lot of them were, I think most relevant documents are from industry on their websites, which are nice PDF documents to have in the clinic in terms of for yourself and your PAs and NPs who may be managing some of these toxicity checks and side effects. But I think this document, at least through expert consensus, summarizes, so there's consistency about how we manage some of the side effects. Again, rare, but is important, is adrenal insufficiency, and often gets missed as to when to consider holding IO, when to consider endocrine consultation, dosing of prednisone or hydrocortisone, the AM and the PM dosing, as well as taper, is very well outlined in this document. Other things that often we see is thrombocytopenia. Again, when to use IVIG, how long do we taper? This document is very helpful and practical. Other endeavors from patient advocacy groups and nursing societies. These patients may end up in a local emergency room, and often they don't know what treatment they're getting. It was different when patients were getting chemotherapy, where you knew that the most common side effect that I'm going to see in this patient is an infection, and they just need to be hydrated and probably admitted if they have neutropenic fever. Not many with new agents coming, and I think it's helpful to know if you're on checkpoint inhibitors versus CAR-T or vaccines, or if somebody in the emergency room, if they should or shouldn't be doing something, or if they're on a trial, some kind of an identification mark is helpful in managing these side effects. Moving on from IO to VEGF, we talked about Pseudomap, bevacizumab. I think one of the key lessons, I don't think there are great documents addressing this in as granular detail as we have for the IO, but some of the ESMO updates and some of the journals that are part of ESMO have included some documents about dosing of ACE inhibitors, as well as calcium channel blockers for renal protection, as well as the hypertension that can happen with some of these agents. The role of palliative care integration for patients with stage 4 is increasingly showing not only benefit in quality of life, but also survival. The initial data came from lung cancer, but the similar studies being reported across in other malignancies, including GI, are, I think this doesn't necessarily need reiteration for all the data that's out there. I think most practices would preemptively have a palliative care consultation already included into their practice. Because of the word palliation, a lot of the institutions are renaming their clinics. So, for example, one of the clinics is called a SYMPAC clinic, which is symptom and quality of life and pain control. So the patients who get referred to those clinics, they don't necessarily, show hesitation, where they could partner hand in hand in taking care of the symptoms, quality of life, and pain control issues as you manage other side effects and treat these patients. The next few slides are from Dr. Luprinzi. He's one of the renowned supportive care experts in the country, looking at his take on what were relevant practical updates from a supportive care standpoint at ASCO this year and last year. Olanzapine, I don't know how many of you have already started using it. The actual paper was in New England Journal in 2016 for the highly emetogenic chemotherapies, and it has been very helpful in patients now that we're talking about triplet chemotherapies and going back to FOLFOXIRI, FOLFIRINOX, and other regimens that are emetogenics or flawed for that matter, agents that patients where they have failed traditional agents. So olanzapine is something that can work and work really well. The main update for this year is 5 milligrams dosing similar to 10 milligrams. There was also a question of, is there added value of NK1 aprepitant as well when you're already giving olanzapine? Other updates included, bone strengthening agents in terms of every 3-minute intervals versus monthly. While a lot of these studies are in the malignancies, example, breast, prostate, and myeloma, which are patients with osseous metastases, but it's not uncommon for us to see patients with GI malignancies with metastases. And now, with all these agents and increasing landscape of many agents in HCC, cholangiocarcinoma, colorectal cancer, we are seeing patients who eventually may develop metastases because now they're living longer, or they may have metastases to begin with. some of the principles of how the dosing is being done for both for zoledronic acid as well as denosumab every 3 months seems to be as good in terms of preventing skeletal events in these patients. Uncommon but important sometimes in a lot of our patients who may have had oophorectomy or in terms of their metastases or surgery for their gastric cancer, in terms of oxybutynin, in terms of decreasing hot flashes. And I'll show you some of the results. So what they defined here in this first study is complete response, which was no vomiting, and then you didn't have to use your rescue medication. So in terms of aprepitant or olanzapine or both, as you can see, the numbers speak for themselves. It is an active agent, and in combination or in isolation, it was helpful in not only preventing any vomiting, but also you didn't need to use any medications from a rescue standpoint. The question of 5 versus 10, seems like 5 milligram looks as good as 10 milligrams. The prescription comes in 2.5 as well if you wanted to decrease the dose in your elderly patients. Other things that are being looked at is the question of, do you really need the aprepitant as well, PO or IV, when you're already giving somebody olanzapine, and typically it's given at bedtime, days 0 through 4, or the day off. That's the prescribing pattern, and a shout out is for a trial that's right now looking at this question of, do we need the addition of FossaPrep, both from a cost perspective and also, it's IV. So this is an ongoing alliance trial right now. I know it's open at many sites in the country, so this would be something to accrue to, which would be helpful to help answer that question. Do you really need the FossaPrep on board when you're already giving somebody olanzapine, which appears to be working really well, and it's a PO that you take for 4 days. And you can also use it for PRN later. This is that oxybutynin for hot flashes. Again, not trivial for those who are having this. It can be a huge source of decreased quality of life. As you can see, both the 2.5 milligrams BID as well as 5 milligram BID had a statistically significant and a meaningful reduction in terms of the hot flash score compared to placebo. And just a brief summary of all the agents that are out there. So if you look at venlafaxine or medroxyprogesterone acetate, in terms of many trials that have shown over the years, citalopram, fluoxetine, SSRIs, pregabalin. Where does oxybutynin fall in? As you can see, these are the agents that all have shown statistically significant improvement and meaningful improvement as well. And things that don't work are, for example, soy, flaxseed. There were trials of magnesium oxide and vitamin E at some point in time. So again, I acknowledge Dr. Lupinzi for sharing these slides for this presentation here. With that, I'll take any comments or questions. Thanks so much.